Thank you. I'm allowed to not only talk about my passion for myopia research today, but also to take a step back and take a wider view today about research with children and what I have learned over the last few years. And central to that really is that you can't do anything unless the children want you to be able to do it as well. So I have gone more and more into research engagement. So talking to children before we ever start doing research and then keeping them updated and talking to them at the end again. And that is the bit of experience that I would like to share today, because there is actually a wider academic framework for that as well that you may never have heard of before. So today's talk is what children want. And it's not moving forward. Why would that be? I just stop. Here we go. So these are my disclosures. So I work with companies who run clinical trials. I am the local PI for several, and through that come relationships with companies who then invite me to come and talk to their employees and talk at educational events, etc. So what I would like to cover today is the issues in working with children in research, what can be done about it, and tell you a bit about patient and public involvement and engagement. That sounds like a very big mouthful, and in the UK we shorten it to PPIE, and it's become increasingly important. And particularly I want to talk about my experience with global majority populations, which in some parts are still called ethnic minorities. And I want to give you some examples where people have been successful engaging with people from hard to reach communities. For example, in audiology, also in studies about real world data and evidence with pharma companies in the lead. Then my particular group of interest that can be hard to reach are children and young people. I want to finish off with telling you about our young persons advisory groups in the UK, but also beyond. These groups exist in Europe, in the US, and worldwide as well. So the issues. Why do we need to talk about engagement and involvement? So on our side, the game changer was that the funders increasingly asked for to prioritize equality, diversity, and inclusion. So they want to see in our funding applications that we make an active effort in reaching out to communities who do not necessarily sit in our waiting rooms and who not necessarily see flyers about new research projects, and who most certainly are never going to respond to flyers and posters that we hand out. And the background to that is that those people who are most likely to experience poor health outcomes are also the ones who are least likely to be involved in research. And there is a long list of reasons for that. And one theme that will keep cropping up in my talk today is trust. So it is people who don't necessarily go and see a doctor, and it is also people who are very doubtful about whether researchers can be trusted. So those are the people that we should target even more, because they have most to gain from what we do. The other offshoot is that we have got this sort of weird reporting bias in the literature. This doesn't necessarily mean in the basic and fundamental science research, but certainly in clinical research, that we publish something that is, we think, generalizable to the whole population. But because we have failed to reach a whole chunk of our modern population, the findings don't necessarily equate to an impact on people in the target disease population. So we need to be a lot more mindful of who will use our treatments in the long run, and we need to include these people in trials. So what everybody knows is that research trials are really at risk to always involve healthy young males, right? Or if you talk about whatever statins for cardiovascular disease, to include men who are white and overweight and have cardiovascular risk factors. But there are loads of other people who will benefit from the research and from the medication. So we need to think about those target populations a lot more attentively and involve them in research. And despite all these efforts, there are still instances where people don't access or are not offered the treatment that they should. And just this week, there was somebody called Lord Victor Adebowale on the BBC News saying, I am an NHS leader, but mum still suffered at the hands of the health service because she was black. And it's absolutely heart-wrenching to read the story. So his mum was a nurse. She has worked for the NHS all her life. And then she developed dementia, and nobody really looked into her complaints of pain and shortness of breath, etc. They diagnosed her lung cancer after she had died. And the question is then, did that happen because she was black? Did people write her off more easily? Did she have less investigations? I mean, we're talking about a chest X-ray, right? So we have to be a lot more mindful of the people that we serve and the people who will benefit from what we do. So what can be done about it? Some people have done some proper research on that. So this group around Bevan interviewed people who advocate for groups who are underrepresented in research. And in the UK, that is often the Black and Asian community, women and families, then young parents, particularly from socioeconomic poorer backgrounds, and always women and families with physical and learning disabilities. And these are the people that we see in our waiting rooms. So it is very, very important that we engage with them. So what they found in these interviews with the advocates will come up in a moment. And it mirrored what another group found who engaged with people directly. So the first group engaged with the advocates for these groups, and the second team, Watterson et al., engaged with people directly. So Afro-Caribbean networks and Asian groups. And they went out to their community centers and spoke to the people and spoke to research delivery staff. We have got whole research delivery networks across the UK that are supposed to link researchers with local communities. But crucial in this first line is that they went to their community centers. So they didn't invite them to come to their research centers. No, they went out to speak to the community in their settings. And what came out, what people agreed on in both exercises, was that community groups don't know enough about clinical research to empower them to actually make a decision about whether they want to take part. There is a lack of knowledge and understanding. So that is something that we should tackle if we really mean to involve them more. So they often don't know what research procedures we do and why. And there are also misconceptions. And there is a whole load of awful history that comes up in the news again and again, where people were basically deprived of their right to give consent and were just exposed to experiments, which of course doesn't happen today anymore. But from that stems the lack of trust from some communities when it comes to research. And they also said that they want the researchers to be mindful that research can also have a negative impact and be a negative experience for people to take part. So when we design our research protocols, we need to think about the research burden for people. So do we need to do all the tests that we ask them to do? Does a research visit need to take 8 hours? What are the really essential questions that we need to address in order to come out with a good piece of science? And on the other side, thinking about positive research experiences, what can we do to make it a more pleasant experience for them? Give them food, give them snacks, explain to them about their condition, explain about the different treatments. So increase their knowledge. People gain very different things from taking part in research projects. And that is something that we as researchers sometimes forget because we are just so keen. Our passion is about finding new knowledge and uncovering the truth underlying and the mechanisms underlying certain conditions. But think of the impact on people who come and take part in your study. So what came out again and again is that people are willing, but they struggle with building trust with researchers. And there is here the term of a helicopter researcher. So they helicopter into a community, gather all the data that they want, and then they are never being seen again. It's much more important to build a lasting relationship, which some universities now call outreach. So you go and you discuss your plans, and then you discuss your studies. Some of the people you talk to might want to take part, and then you take them with you. You talk about, you go back and tell them about what you have found, and you involve them in disseminating your finding. So people really need to build a relationship and a trust between the community, the target population, and the researchers. They want to be involved from the beginning. They don't want to sit in the waiting room and see a poster about your study. You're much more likely to get people to sign up for your research if you have been there before and have discussed the plans with them. They want to know about impact. So what is meaningful to them might be that you actually have changed a treatment pathway, or you have uncovered a new mechanism that is important to them in their everyday life. You have to check your communication with people who are part of the community. Now, even if you think that what you've written is clear, it's always worthwhile giving it to somebody in your target community to have a look at it as well, because they might still come up with improvements and making the wording simpler. And never forget to think about what life looks like for them. They might live in very, very different circumstances to ours, and you need to think about both what the research means to them and also what later treatments might mean to them. So think of life in their shoes. On the positive side, if you do engage with patient and public to design and carry out your research, it will undoubtedly improve the relevance of your research. Whatever you come out with will already have been sense checked by the people whom you're targeting. So everybody will understand much more easily why something is important. If I can't explain why my research is important to a 5-year-old, then I really need to figure out whether my research is that important, right? Because they have got a completely different value system to me. And if I can't make them understand why my research question is important, it might not be that important. It increases the feasibility. So if you have designed a beautiful protocol and you've got funding, luckily, you might still find yourself in an empty room and nobody wants to sign up for your trial because you've put some tests in there that children can't or other people can't access. It might take too long. They can't take time off work. They can't take time off school. And you might just find that it's really just your pet idea and you have no wider buy-in from the community. Whereas if you have engaged with the community from the start, they will already have told you how you can reach out to people who will sign up to your trial or your research study, and how to make your protocol so it's of the least burden possible to them. At later stages, they can help you with dissemination, telling you which channels to use. And so far, nobody has asked me to do a TikTok movie, TikTok, whatever clip, thankfully. But, I come to that a bit later. It really changes how you think about dissemination. It's not just the paper. It's not just the poster, because that is for us. That's for the researchers. But we need to feed back to the community as well to show that we value their contribution and explain what the impact is on them, for them. There are a couple of different sort of categories of patient and public involvement. One that I quite like is this one where they have suggested there are 4 types. If people are just participants in a research study, that's on the right here, they might complete a survey or they might come for some tests. They are an active participant in a trial, but they have no input into the way the research has been set up or is being run. Consultation is the next step up. So you go out and ask them to give feedback on how you're doing the research or about the plans for the research. One level up again is engagement. So you share information. For example, you hold an open day for myopic macular degeneration or sleeplessness in children or whatever. So you share your knowledge and the research findings with people, such as on social media, or you hold an open day that's quite popular here at Moorfields. So where you bring people together who have got a certain condition and you have a good exchange of opinions and knowledge about that particular condition. And the next level up, the fourth level, is then involvement, where you go out and really ask for people's advice on helping you design and carry out your research project. And the people you engage with are then commonly known here as PPI partners. And in my clinical funding applications, I always have one lay advisor. So that's somebody with a condition, or in my case, a parent whose children have myopia, and their children now are teenagers, so they can also feed into the discussion. So they have a very formal role as advisors during the application and also during the running and the dissemination of the research. I also like this ladder that is taking it a step further. This goes up to co-production. So it's similar to the one that we had before, in that you've got the steps of educating, informing, consulting, maybe engaging, where you ask them to express their views. And then come the two top levels, co-design. So you allow people in to your design team. So you ask them how to design the research based on their lived experience and their ideas. So they do have a genuine influence up to the starting point of your research project, but then it stops. So that is then where the last level comes in, where you acknowledge that they have actually might be able to make an equal contribution to the whole of your research. So you have them involved in the beginning, the funding application, the ethics application and patient-facing documents. They might then sit on the trial oversight committee. And whenever there is a strategic decision to be made, they are there to make their voice heard as well, all the way down to dissemination. So co-production is something that's really important in the later stages of research. So when something is on the cusp of becoming relevant to the wider population, it's of course not necessarily relevant at all when you're in fundamental science and you're looking at one particular mechanism for something. But there are also very interesting co-production projects where the question came from people who had a condition or an interest, and they then found researchers to work with them in order to find an answer, to design the research. Arthritis, for example, is one area where that has happened several times, that a patient support group has put together what matters to them, and then they have commissioned a call for research where people would then work with them. So co-production is definitely something to consider when you come to the later clinical phases. This is a graph which is just typical for anything on PubMed. So as the years go by, there have been more publications, but for patient and public involvement and engagement, the number has really gone up quite a lot over the last 10 years. And mostly so in terms of geographic location in England, Scotland, USA, and Canada. So these English-speaking regions are sort of leading the way. And as I said before, I think the main driver have been the funders. The funders look for impact of the research, and they want to see that we reach the people in the underserved communities. So they have actually put a lot of resources into PPIE, and they have got mandatory boxes in their application forms, and you cannot complete them the week before you submit your grant. You need to have engaged with people way before that in order to run focus groups, workshops, really have meaningful interactions with people. And then in your funding application, you also need to detail how you're going to carry through the PPIE activities throughout your project. And I think it is because these funders have made it mandatory that these countries are at the top of the league tables in PPIE at the moment. In terms of what type of research or what type of PPIE activities generated the highest hits here, the four top ones are community participation, health, as in health research, participation, as in including people, and care, then followed by intervention and education. So the areas are really mostly health research and new interventions being tested in the health and care sector. So going to some examples then, and I'd like to start with the global majority populations, because where I work in London, they are nearly the majority now anyway. So Leicester is the first city in the UK where there are now more people from ethnic minorities than white people. And the same phenomenon will happen in London in the next few years as well. So what we used to call ethnic minorities will actually be the leading chunk of the population in many cities in the UK. So in these workshops where they have worked out where the hurdles and the barriers are and how we could overcome them, they've come to the gaps in understanding, both about conditions and about clinical trials, what they are for, what they are, and what it means to take part. And again, trust played an important role. And I have learned from first-hand experience that the best way to build trust is to link up with somebody who is in the community already. So community leaders are one. So if you can go to their church meeting, community center meeting, mosque meeting, and somebody introduces you who is a leading figure, a figure of authority whom they trust, they listen to you, and then you tell them about what you want to talk about, and then you make yourself available to questions. And there are so many questions they want to ask and never get a chance to ask anybody. So it is really important to engage, but to have a trusted person next to you who will sort of vouch for you. And this is not for them to sign up to a research study. This is to be building relationships and building trust. And those people can then also help you to navigate all the sensitivities about language and about culture during the discussions. Another example of that is actually not a community leader, but in the UK, we now have community research facilitators or engagement facilitators. And I have just had a beautiful experience of that in one of my studies, where I wanted to reach out to the South Asian community in a poorer part of London. And a lady who lives and works there as a research engagement facilitator helped me run workshops and focus groups. And clever as I am, I thought the easiest way to get consent rather than having these clumsy bits of paper would be an e-consent process. And then, of course, I started to worry whether they would access it. And the night before the first workshop, only very few people had signed the e-consent. So I printed out lots of papers and took them with me as well, so they could sign the consent on the day. And then I was in a room with lots of ladies of South Asian heritage, some of whom did not speak much English at all. And I said, well, before we do our focus group, we do need to go through the consent process. So let me explain. They had read all the information leaflets. They didn't want me to explain. I said, I've brought these papers. You can sign them here. They didn't want to do that either. What they were waiting for was the community facilitator to say, this is Annegret. She's a lovely person. Look, she's got her badge from Moorfields, from UCL. You can trust her. And the first step is you just open your phone, do this QR code, and complete the e-consent. Within 5 minutes, the whole room had done their e-consents. They had looked at it before, but they didn't do it because they didn't know me and they didn't trust me. But having Lily with me, who lives there and works there and knows everybody, then it was okay. Right. So it's not really just that there are digital barriers or language barriers. The main barrier, in my experience, is trust. One group then developed these storyboards for different communities, so South Asian, East Asian, the Black community, where they explained things like the clinical trials. They highlighted problems such as language barriers. This is one for researchers as well, to highlight to them what South Asian participants might particularly struggle with. So clinical terminology, that for language and cultural background, there needs to be a safe space where people can feel free to discuss their experience, etc. And they also add their frustrations. So here it is, it's difficult to get a GP appointment and to talk to a GP properly when you come from the South Asian community. They might not take you as seriously. And I get the same comments about optometrists, that they say, I should go out and explain to the optometrists how to explain things to the families. So there is a whole background that needs to be unraveled in order to get through to what we really want to talk about, so our research projects. Yes, and if you co-create these posters or storyboards, then you can use them next time round, both to educate your students and sensitize them a little bit to what matters to people, and also to have like a blueprint for what to work on when you want to engage with different communities. A second example was audiology research. So they were also keen to capture views and experience of a wide range of people. And they wanted to particularly reach out to people from ethnic minorities. And what they learned in the discussions with these communities was that they have to be very careful not to be judgmental in their discussions. So be careful with what you say and don't stereotype, for example. So build your relationship, show empathy, show active listening and reflect back on what they are saying, and really show empathy to life as it is for them. Don't expect that their life is the same as yours. And once you do that, you develop a sort of habit to speak the way that is appropriate for a particular community. And then you can also tailor your inclusion strategies better because you are more aware and more conscious of the barriers that people might be facing. So they came up with this diagram suggesting you need to set up a relationship, develop the relationship, work within the relationship when you want to do your research. Then you reach a sort of plateau where everything is going smoothly. And then if you only have a limited project and you never want to go back, then also be clear about that. So don't just disappear. At least give them a presentation and thank them for contributing and say, this is what we've done so far. Now there will be a gap because we've run out of money and we need to apply for more money. And then if something good happens, then we come back to you. Or if it's an ongoing project, then do invest in maintaining your relationship with them. In terms of how to structure your thoughts, I thought this could be helpful. So write down for yourself what you're trying to achieve with your public and patient involvement and engagement. So is it that you want to reach a heterogeneous range of people who have a certain problem? Whom can you speak to get advice on prioritizing your research questions? Should you involve the PPIE group, so members of the community, to find out what matters most to them? That's not always appropriate for your research project, but it's something worthwhile thinking about because then you will have a bigger impact. Now, if it's also meaningful for them, then go for those research questions first. And which research methods do you want to apply? That is definitely something that your PPIE group can help you with. And then you can tailor your activities and your outputs to those specific questions. A third example is this paper on real-world data and evidence research. So this is very late phase. And what this team found that people didn't really understand what this was all about. They didn't understand what real-world data and real-world evidence were. They are really big mouthfuls anyway for any of us, aren't they? So this was driven by pharmaceutical industry who were looking at late phase work. So after they have got their marketing authorization. And just from seeing people struggle with the concepts, they understood that they needed to start way earlier to co-create resources to enable a meaningful interaction. So to explain to people what exactly these concepts mean. And they then designed interactive workshops, recorded them both on audio and on video, did a thematic analysis. And what they came out with is similar to what we already said, that there is a lack of trust, a lack of understanding of what the researchers were talking about, a need to educate the public and the researchers so they can talk to each other more effectively. And they came out with recommendations that fall into 4 broad themes. One is equality, diversity, and inclusion. So people said, we want to know about how to get more diversity involved. So they are very open to the concept, but they don't know how to. People want to feel valued. That means being more flexible, let them have options, make their life as easy as possible. So they want both the positive feedback and feel valued for that we ask them for their opinion and also value the contribution they make. Ownership and understanding. I think there should be involvement right from the outset. I think it was about feeling part of it, about feeling confident. Absolutely spot on. This is exactly what people want to do. They are very generous with their time, but they do want to feel a sense of ownership over the project. Evaluate, measure, and share the impact. Why you are doing this? Will patients have better treatment because of the research you're doing? Right? So we often forget that. We have got one specific research question because that is the way we have been trained to see like the most important bit in the universe of data and facts that are already known. But people don't know that. They want to hear that what impact your research is going to make. And if your project at the moment won't have the big impact, tell them that. You say, this is the background, this is where this might lead to. But before we can go on that big journey, we need to answer these smaller questions first. So as long as we embed it into the whole story, then people understand what we're talking about and have this sense of ownership. This group, if you want to look at the presentation and the references later, they have set up a whole framework of how to go about it. So this is again about this pre-relationship, during the relationship, and what to do afterwards. And they said, remember that people can not only help with setting the priorities and designing your research, but even before, for scoping projects, and they can help you recruit other members of the public to join your PPIE panel. And once you have done your research project and you have engaged, they can also help you with exploring the impact of the work that you have done. So really just think about them a lot more than just when you are confronted with this box on your grant application. I'm a pediatric ophthalmologist, a children's eye doctor, so my target group are always children under the age of 16. And how do I get to them? So easy way would be to speak to the parents, but they don't really give me the voice of children. And children do have their own opinions and anxieties and expectations. They just express them differently. So I think it is absolutely vital that we do PPIE with children and young people directly, because they will give us a different view of the problem. For example, I was absolutely flabbergasted, this year, when a 15-year-old told me that when she was 3 and had to do eye patching because she had a weaker eye, so she had a patch on for several hours a day. Well, that was the plan at least. She ripped off the patch after her parents had sat her down at nursery and before the nursery teachers took over. So the parents were happy because they thought the patch is going to stay on. The nursery teachers assumed that they were doing the patching at home, and none of the adults ever had a clue that this clever 3-year-old was manipulating and sabotaging the whole treatment system. No, and she never told anybody. She just didn't want the patch, and she had figured out that all the adults were against her, so she had found her way of dealing with the problem, and she still remembered that at the age of 15. So that was something that had absolutely never occurred to me. So they give you a different view of the problem. They will also tell you what research or which improvements they want to see. And it can be something like, I want eye drops that don't sting, right? So you have to listen really carefully to what they say, because they are talking from their experience as well. Similarly, what research burden is acceptable to them. Now, the research burden will also be linked with the research question. So if you're doing a first-in-human genetic trial, gene therapy trial, of course, it's very, very important that you get every scrap of information. And those poor kids have an enormous research burden, because it is so important to find out whether this very new treatment works and whether it has got any adverse effects. But in many research projects, there is no need to put them through a particular test that takes 2 hours 3 times. You might need to do it once, if at all. Maybe there is a better test or equivalent test that's not so hard on children, but that would give you the same information. Our young children and young people have been looking at our information leaflets about conditions in the clinic and for research studies for years, and they're really, really helpful. They can just tell you what is still too much jargon, or where children wouldn't understand what you're writing. They're always asking for more illustrations, or maybe even cartoons like a storybook, etc. So they're really very well informed when it comes to information leaflets. And with training, they can even be peer interviewers if you have a qualitative research project. We were surprised to see how much easier children find it to talk about their lived experience as research participants when another young person is sitting in on the interview. Now, you need to train that young person to be a peer interviewer so they know that it's not just a loose discussion, but that you're following a topic guide, etc. But the dynamics are a lot easier for the child who is a research participant if they have somebody in the room or on online Zoom or wherever that they can relate to very immediately. That takes me to the bigger background. There is actually something like law that supports all this, and that is the UN Charter on the Rights of the Child. And that has been around in the clinical area for a much longer time than in the research domain. So children actually have a right to make their own voice heard in everything that impacts on them. So there are clinical standards about tests and standards for tests and procedures in children. But in research, we have been lagging behind a little bit. But Article 12 of the UN Convention of the Right of the Child absolutely states that every child has a right to express their views in all matters which may affect them. So that means that they definitely have the right to sign their own assent form. And if they say no, it's no. And that can be a very difficult conversation to have when the parents don't agree on the child saying no. And then there might be a need to explore all the issues more deeply, particularly if you feel that the adult has got more foresight into the development of the child. But then there needs to be an effort to convince the child that taking part in the research would be the right thing to do. But broadly speaking, if it's not life-threatening or sight-threatening or something on that level of importance, then the child has to have their own voice heard whether they want to take part in research or not. But children also need to be involved in preparation of research and running of research, just like all the other vulnerable populations that we've talked about before. And if you give them the appropriate training, they are perfectly able to talk about priorities for research, help you with research design and dissemination. What can young people contribute? So I've then tried to bring together a few examples of our own, but also others. So one team here has produced an app that should facilitate access to more young people so that they can be your big digital PPIE group for young people's projects. And they sat down and tried to figure out what young people could contribute over and above what you would get in this case from mental health professionals and trained PPIE leads. And they figured out that the unique voices or the unique bits of information they can contribute is that they could give feedback on the use of the app and how they would refer others to use the app, how to explain what this new app is all about when talking to young people, as well as giving general thoughts about the potential audience. And then there was also an overlap with the professionals, so they can contribute to making this meaningful by discussing the aim of this new app as a reach out or outreach app to reach people who can give you PPIE support. They can give advice on how this app could support PPIE in addition to traditional methods, which are usually group meetings, which features should be in the app, how to make it, what it should look like so it's easy to use by young people. They can give advice on ethical considerations and accessibility. And they actually did have a massive impact on every step of the development of this app. So they talked about how they would be approached by the app, like notifications, and pointed out that if there are too many notifications, then young people would just delete it off their phone again. They suggested that it should be advertised to students on psychology courses so that those people who need some PPIE input but don't know how to find people could use it, and that the app itself could be advertised, for example, through posters at universities and mouth-to-mouth feedback. They also gave feedback on the whole idea of having the app and how to digest what it should involve. So they asked questions about how the app would accurately verify age. They were optimistic that it might enable and empower more young people to be involved in research. And changes that they suggested were actually incorporated, such as this push notification when there is a new project looking for PPIE opinions, or whenever projects that they had liked had a new request or an update. So they had a very active involvement throughout the development of this app. And this is what some screenshots look like. And what really struck me is that this looks so simple, right? So you have got a high contrast font, big letters, very simple yes, no, or thumbs up, thumbs down, one question per page. You can see some polls where they can then see as a feedback to them what other people have said. And there are updates. So the things that they were interested in, they will get a notification from time to time to keep them informed about what is happening to the project that they have contributed to. Another example was a very dramatic one during the COVID-19 pandemic when all these new trial designs popped up. So the adaptive platform trials where new treatments could be tested in parallel so that promising treatments were fast-tracked. And one group developed a platform trial together with children and parents and carers. They asked them, which domains should we include as outcomes, sedation, and what interventions should we test? And they gave very clear steer that at the start of the trial, there shouldn't be more than 3 domains, and that for them, the most important outcomes were the child's quality of life and survival. So they had a very clear notion that mortality was important in a COVID trial. I also liked when it came to suggested outcomes that were missing, that location of the child at hospital discharge and a month later was important. Because if you have a child in a hospital 500 kilometers away, that's a huge burden for the family and the other siblings. So that is something that the hospital specialist hadn't really thought about, but it was something that really mattered to the families. Industry has joined this whole PPIE enthusiasm because they can also see that just having these regulatory approvals doesn't really translate into uptake of their new interventions. And they have done their own studies together with PPIE experts to see at what stage they could draw on PPI groups and input in order to make their research more meaningful. Now, this is a bit sobering. This study looked at how much is actually happening of all this good stuff that we know about PPIE with children and families. How many studies are actually initiated or directed by children? In how many studies children have collaborated with adult researchers or have at least been consulted, or in how many studies have been published where children were not involved apart from being research participants? And this is the number. So you can see the number of studies in which children were not involved at all is in the double digits. Consulted, mostly not a lot. Collaborated with adults, a few. But initiated or directed in the research proceedings, 0. So it is hoped that over the next few years, we will at least increase the numbers in the 2 middle ones, move away from not involving children in the design of the research at all. So we have started our Young Persons Advisory Group in 2019, so that's now 6 years ago. In the UK, there is an organization called Generation R for research, Generation Research, and they have promoted this setting up of children's groups, children's advisory groups in all the big hospitals that have pediatric services. So the umbrella organization is Generation R. They have a website. Our own group is called the IYPAC, or the Young Persons Advisory Group for Eye and Vision Research. We have a page on the Generation R website where after every meeting, and that's about every 2 months, we publish our blog. So at the beginning of each meeting, one person has to volunteer about writing a blog, and then we upload that within a day or 2 of our meeting, which is also great for us as a resource to look back onto what we have done and what we have achieved over the years. So the last meeting Though we actually had an update after the last meeting because these 3 boys went to a meeting in Athens on behalf of our group, where they talked about how children can contribute to research in rare diseases. We recently had our second lot of t-shirts and sweatshirts printed because we're going to go to an international conference this summer where we want to look like a team. And this is one of the last activities that we had in one of our sessions. And these are all little animals. So people were talking about different group of health professionals and thought one way to make this understandable to children is that each staff group is represented by a different animal. This is what our meetings typically look like. This is the important bit, right? So there is lots of arts and craft stuff, pens and sticky notes and paper. Food is extremely important. The lunch break is why they really come, I think, because that is when they are bonding and have their time with people who also have conditions or not, but they meet every 2 months. And over the years, they have really become a lovely group and they want to meet each other and chat with each other. We move around a lot because children don't like sitting down for 4 hours, obviously. We stick things on the walls. People can write their opinions and then stick it on there. And then if they want to, they can talk about what they have written. Children often find it harder to say things than to write things or to draw things, which is fine. So we give them lots of things to do and we listen to what they say when they talk to each other during these activities. And if they want to give a summary at the end, then we invite them to do that as well. And that works with really young people as well. So this young lady is 5. And she stuck her sticker onto this river of life for a condition that we were talking about. And then she explained to me, but really to everybody, what she thought about the project that we were talking about and what was important for children. Creative methods are really what makes this work, right? So you cannot sit down and ask them a question and expect them to come with an answer. You need to sit children down in a circle. This is our retina model. So you can see the photoreceptors and then how cells are the information is integrated and sent to the optic nerve and how they are embedded in their nurturing structure. So you have to give them something that they can understand that's really, really simple. Being circadian researchers, you might have spotted that there are some wearable light sensors. So at that time, we were discussing a myopia project. In one of our very first meetings, we used this embossing activity to just think about the eyes and how eyes and vision are important and what people know and what people think about their eyes and vision. We have Play-Doh, so Play-Doh as a modeling clay activity. And there it's not important what they make. It's important what they say to each other whilst they are working. And then a person from the table can present their thoughts at the end. But they talk a lot more when their hands are busy. And similarly here, we had something on the floor. So one activity was to write their opinion and ideas. We call them ideas on the paper. And then we wanted to rank them in order of importance. So they got little cards to bring into order. We've also done our own group evaluation that has even been published as a scientific paper. And the kids did the filming and the interviewing with each other, on each other, and they absolutely loved it. Very briefly, some examples in my research. We have consulted with parents and children about patching treatment in 2 trials so far. They found also on what they thought about the treatment, how easy they found it to use. They felt enthusiastic about using a movie watching approach instead of patching. They gave us the advice that 1 hour a day in one block is difficult for children aged 3 to 8, but 2 times 30 minutes would be okay. They didn't like the idea of coming to the hospital every 4 weeks, which was what the fundamental scientists wanted. But they said every 3 months was okay. So we reached a compromise. They also gave some really good input on the health utility tool. So we wanted to do a health economical analysis. And in the UK, this particular tool has been put forward, but they had a look at that and said that's completely hopeless. And we don't think that extracts information that is relevant to our situation. And then one recent example from this trial, when we had finished, I typed up a lay summary and took that to a YPAG meeting and said, look, this is what we think about sending to the families who have taken part in the study. And they had one look and completely rejected it. They said, nobody's going to be interested in reading that. You need to make a little infographic. And then in that session, we hammered down on what the text should be, which questions would matter to people, and we put together a draft infographic, which I then embellished a little bit afterwards. And that is what we sent to the parents. And that was also published with the main paper in the BMJ Open. We've done a lot of work of myopia with our group, answering lots of questions like how to describe what is myopia, why it is a problem. Would children take 7MX tablets? That's a project that never happened, but yes, they would, and they were very interested to learn about a chemical compound that's also found in chocolate and coffee. Red light treatment is all the rage in myopia. So we brought some red light goggles and said, would children use that? And they said yes, because it's quite calming, and they helped us design a logo. Research about new tests to measure. This is a biometer, a handheld biometer that measures axial length. What do you think about that? They said anything where we don't need to put our chin on the chin rest is a plus. So that looks really good. One that you will all know is the sensors on the glasses to measure visual behavior. That is something I'm still struggling with, because they said absolutely not. They don't want to have anything on their glasses that other people could see, because then they would be teased and bullied and people would try to rip it off. So they didn't think that they could wear it to school, for example. But, we're waiting for things to become smaller. How to tell people about research. So they said social media, and also when you want research participants, give them a small gift, show your appreciation for them giving you their time and their effort really to take part in research. We've designed cartoon booklets instead of the conventional information leaflets. We're doing a big study at the moment with several workshops with children and families to find out what outcomes matter to children and their families when it comes to myopia. And one big surprise for me, for example, was unaided visual acuity. So they don't want to become more and more dependent on the glasses. If you say a treatment will make you less myopic and you can see better in the distance without your glasses when you're a teenager, that is a plus for them. And we have done our first little advocacy campaign together to tell other people about myopia as well. There is a wider network in Europe now, the TEDdy network, that organizes these special events at European level, like this meeting in Athens. They are slightly more slanted to rare and genetic conditions. And then there is this big international organization called the International Children's. It was originally advocacy. It's now advisory network. And they have a summit every year, either in Europe or in North America. It's alternating. And our group has been taking part in this for a few years now. So last year we were in Bari in Italy, and this year we are going to Montreal in Canada. And that's a huge opportunity for children to meet other children with conditions who are also used to contribute to research. And pharma companies come and use it like a big PPIE exercise. So they bring their questions and ask the children and the parents to work on them during the summit. And they have a jolly good time in the evening and do lots of interesting activities. So our kids just absolutely love it. Tips for if you want to start your own YPAG: involve them early. Make sure that you are clear about the role for the young people and the families. Think carefully about whom you want to involve. Do make sure that you've got consent for them participating in your team, because they are underage. So the parents need to give consent for them to be in the group. Give them the training about all the stages of the life cycle of a research project, like confidentiality, what the patient information is for, etc. Give them a reward. Ours get Amazon vouchers at the end of a meeting because that is what they wanted. And it's about £5 per hour. So they get a £20 Amazon voucher. But by now, that is really just an acknowledgement. They don't come for the money anymore. They come for the friendships. Make sure that you follow safeguarding procedures. You don't want to put your young people at risk. Remember the logistics, so signing in, keeping a register, making sure that everybody knows what happens in case of a fire alarm, these really basic things. Try different methods of keeping in touch. So we have learned there is no way of keeping in touch between meetings. We send them emails, but everybody is busy. They don't engage with that. The older ones have started their own WhatsApp group, but that's up to them. That's got nothing to do really with the YPAC group itself. And ensure that they are given feedback. So when researchers come and ask our young people about their research projects, we always ask them to come back if they get the grant, once they have submitted their ethics application, etc., so that the kids actually see how their input has shaped the project. So feedback is also something that really makes them feel valued. Thank you. That's the end of my presentation. Thank you very, very much for listening and for sticking with us for the full hour. Thank you.